Good morning, everybody. So, thank you, first of all, for joining this webinar on setting up our low vision clinics. So, I am Fanindra from Vision 2020 India. So, we have the resource person, Dr. Tanuja Brito. She is actually ophthalmologist and consultant for low vision of for CBM consultant and also trainer and the deputy director and the head of the department of the Joseph Eye Hospital from Trichy, Tamil Nadu. So over to Dr. Tanuja. Thank you, Dr. Tanuja. Please go ahead.
Thank you very much, Dr. Fanindra, and welcome everybody. Good morning for joining in, and thank you for this interest in low vision services. At the outset, I'd like to thank CBM and Dr. Sarah, Madhavan, and Ravi for all their help in setting up this, and also I have to thank CBM for being where I am today. They trained me and they helped set up our low vision services here in JEH. And I also want to thank Dr. Nelson Jesudasan, Director of and Medical Superintendent of Joseph Eye Hospital, for his support to us, to me especially in this venture in low vision. We started low vision in Joseph Eye Hospital in 1999, and ever since that there's been such a gradual growth. So I'd like to share about low vision, how to start low vision services actually, because now the need is increasing and the interest is increasing. And there's so much variety of inputs on this. So I would like to, on outset, tell you how to set up at a basic level. To start, what you need. So you're most welcome with your questions later. What I'm be saying is only an outline. So you will be, you are free to ask me at the end of this, and we can go back to those slides. So thank you for patient listening. Yeah, we go. Yeah. So low vision clinic provides, should provide appropriate, affordable, and accessible services. And the main aim is to integrate a person with vision loss into the community by enhancing residual vision. So far, a person with a vision loss will be shunted into some isolated homes, but low vision is such that you put the person back into the community. So what are the basic components of low vision? The main thing about low vision is people have some amount of residual vision. Though they have vision loss, they have some residual vision. So what we do is we assess this residual vision both clinically and functionally, just to quantify and qualitatively measure it. And then once you know how much they have, you prescribe and provide interventions, train them in use of prescribed interventions, and you have to refer them for other resources and do a lot of follow-up. These are the basic components of any low vision service. So what is the essentials for low vision delivery? The main thing is you need a modus operandi, that is a protocol. How do you go about it? Where do you start? Where do you end? What is the end? So you should have a protocol, how you do it. And then the second thing, most important, is trained human resources. You really need to train them in the right way. And then once they are trained, you need to have basic equipment and infrastructure. What is infrastructure? These are the common questions that we are dealing with. And what are the other support services that you will need for a low vision clinic? So coming to the protocol, the first step is to identify if they are low vision or not. Because people with vision loss can be there because they might need a cataract surgery or a refractive error. So once that is done, and then beyond that, everything is over, and then you have finished every intervention, medical intervention and surgical intervention. So, and then they are still left with vision loss, then you do, that's when you really identify them. So identification, positive identification that these are low vision patients is the first step. And once you identify them, what do you do? Once you identify them, you have to assess them. So assessment is two types, clinical assessment, and then you don't stop with that. Once you finish clinical assessment, then you do a functional and an educational assessment. Clinical assessment is, we'll be seeing that. Clinical assessment is where you quantify how much vision they really have. And that also leads to your device's prescription. Whereas functional and educational assessment is how are they using this vision? Once you enhance it, how well are they using it? And functional and educational, how are they using it in everyday life? Are they able to use it in education? And how are they using it for their daily activities and so on and so forth. So that is assessing. Once you are done with all your magnification, everything, then you have to again refer them or do this functional and educational assessment. So then you finalize your prescriptions, and so that is interventions. But one thing in interventions is low vision interventions are so has to be you have to do a lot of training to use them, because there are some particular principles for and calculations. So you have to train them how to use the interventions. Do they, for example, do they use it with or without the distant prescription? Do they use it with or with the bifocal? How are they supposed to hold the device? How are they, when are they supposed to use it? All this comes under your training part. And also you have to train them how to read, write, do their daily activities with the interventions that you have prescribed. And once this is done, yeah, then what happens? Most often this follow-up is a problem, because our patients, once they are done with one visit, then they feel everything is done. But as we know, low vision, vision loss is usually progressive, or there are changes, especially with age and other things. So follow-up is very important. So again, follow-up is mandatory. You have to know, is there any change in their disease status? Is there any change in their vision status? And how are their interventions working out for them? So follow-up is a very, very necessary and mandatory part of low vision services. So this is a protocol that we follow here. Most of us follow. So with this many steps, what are the human resources that we need? We must understand from the beginning, it's a teamwork. It is not that I alone am able to do it or I should do it. And so coming to the team, who are the team that we are looking at? So there are two types of members. One is whom we call as clinical. The others, I've named it as non-clinical, but usually they are called functional people. And then there are others who will be doing supportive work for us. So clinical people means eye care people. That's what. Ophthalmologists, optometrists, refractionists, vision technician, people like that. So, and non-clinical people can be anyone. The difference between a clinical and a non-clinical person is a clinical person knows all about refraction and calculation, how to prescribe devices and such that. A non-clinical person is someone who does not know anything about refraction. That is the basic difference. So, and they are the people who will be doing your educational and functional assessment, and who will help out in the field. So I name them as non-clinical, but normally we call them as functional people or rehab people. So who are the people who will come under this are the rehab professionals, educators, special educators, everybody. Any type of social workers, and any type of therapist. They could be occupational therapists or physiotherapists, anybody who we can train them to do this functional and educational assessment and give us help to the patient. The other things that you will need is in your team, I put it as admin workers. These are the people and accounts people. These are the people like, who will be helping you with other things other than this assessment and interventions and training. So let's look at what is their job. So who does what? So primarily, clinical people or eye care people will be doing the clinical assessment. That means and they will be evaluating just like any other thing, refraction, magnification, and then you prescribe distance and near, and then optical devices. And you also have to train them how to use these days, this aid. So follow-up also comes necessarily under that. So you quantify the vision just like any other ophthalmologic preparation. Like ophthalmic patient, like you do a slit lamp examination, you do fundus examination, and then refraction, distant correction, near correction, and then you try magnification. Then you look at their contrast sensitivity, field, and how good is their near vision, and then you prescribe their distance and, like I said, the normal spectacles that they need, and then you go on for their optical devices that they need. And then you train them how to use these optical devices. The functional people, like I said, what are their roles? So primarily, they will be sitting and counseling with the patients. We also will be counseling them, but they will like take over and say, tell the patient how they can use this, what are the problems, find out. They can actually help you finding out what are the day-to-day problems that these people have. What is it that they are, where is it that they are having some problem? So they will help in not only in counseling what to do and all that, but also to find out what are the needs that a patient has in everyday life. Because we are not dealing just with a diagnosis or vision loss. We are finding out how are they handling this vision loss in their day-to-day work. So these functional people will help us by finding out in their day-to-day how they are able to manage. So that's what these people can do apart from what we do. And then a lot of counseling goes into this because they have to tell them how they can adapt in their situation. And they will do a functional assessment in the sense how much it also includes your educational assessment. Are they able to read? Are they able to write? Are they able to move around? So all this, are they able to do their daily activities? So they assess that. And then based on that, with the optical devices, they do this and then prescribe or recommend non-optical devices, primarily non-opticals that we will be seeing later. What are the non-opticals? And then they also do a lot of training, how to walk, how to read and write with a device given by the clinical people or eye care people. And also a lot of guidance goes into this, like, where to go to school, what vacation to take up, do they need any training, or do they need even physiotherapy, especially in special children and all that. So all this sort of guidance, they can career guidance, everything. So, and a lot of counseling again is required. So these people will do that part of it. So, and we talked about supportive services people, and apart from this, we have, these are the two primary areas, but out of this, we also need a lot of what I put as others. What are the activities? That is, once you do all the assessment and all that, record keeping. Recording is so important. So you have to record. You have to be very meticulous in recording what are the devices, at what distance, how are they able to, even their day-to-day activity, are they good with light or without light, all that sort of thing. So record keeping is so important, and recording is so important. So keeping these things, especially files, are very important. Now we have computers, so even then, so those are the other activities, recording, then billing. So how are you going to bill them? What are you going to look at? It's all about finances. So I said accounts. Are you going to give it free of cost? Are you going to give a subsidy? Are they going to pay full time? How are you going to manage this? Are you going to look for sponsors? All that comes under that finances and billing and all that. Then again, scheduling appointment, follow-up. This is mainly follow-up, contacting the low vision people and, finding out where they are, what are they doing, why they have not come, and all that sort of thing. And also communication. In the sense, if you are going to do some placement and all that, you have to you have to know people who can take this child in their school or in their business or whatever. So a lot of communication. So all this sort of other work around it, you have so many activities which has to be also looked into, or shall I say, we need a person to do that. The functional people actually can do that also. They can do all this, I would say all this guidance under counseling and all that. You can add all the other activities with that. So with so many activities and so many people, we would be wondering, so many stages in the protocol, what is it? How many people you really need? How many you really need? Anybody would like to offer? So if you're muted. So I would just, this is the WHO recommendation. So an ophthalmologist and a special educator or a rehab person. That means one eye care person and a non-eye care person. These are two people are sufficient to run a low vision clinic, to provide the diagnosis and services, care for 10 cases, minimum to 10, 15 cases also per day, and cover a population of 5 million. This is WHO recommendation. So you can go up and down on this, but definitely you need two people in the team, an eye care person and a non-eye care person who will help your functional. So this non-eye care person needn't necessarily be a special educator. If it's a hospital or a clinic, then you can always train a ophthalmic nurse or a general nurse who does not know. See, the thing is, they should not be forced to do, or they should not be doing refraction. They can be anybody who does not know refraction, but who can help, or who can be trained to do this. Could be a counselor or anybody for that matter, with a little bit of education. And education also, you don't need a master's degree in social work or anything. +2 passed in a rural area is more than sufficient. If you want to be a little high-fi, then maybe a person, excuse me, with a science background, preferably a graduate, it's more than sufficient to train them. So you can train them, provide all that, and help them to handle patients. And normally these people, as we go and progress, they are very supportive and very good for us. So that's one thing. So what I'm trying to say, why I'm saying this is, you must understand that low vision is teamwork, and it's not all about eye care. It's not all about low vision and devices. I mean, clinical assessment and devices alone. There are other things involved in that. That's right. So then let's come to the equipment. What are the equipment? What I call as basic diagnostic equipment, equipment for clinical assessment, and equipment for functional assessment. So let's look at that. So basic diagnostic is like your slit lamp, your refraction set, retinoscope, everything, and your vision charts, fundus examination, all that goes under that. So in this, I want to add something. Many of the patients, your autorefractometer does not work. You have to be very sure of your refraction. That's very important. So a refraction set, especially those with the big aperture lenses, are very good. So the big aperture lenses are the best in this. So otherwise, it's just your slit lamp, your fundus examination and all that. Then you have vision assessment. For vision assessment, you have the different charts, mostly Logbar charts. And then you have your functional assessment kit, your magnification set where you all the devices, optical devices, and your other interventions. So we will see that. So what is this assessment kit is? Anterior posterior segment instruments, like I said, refraction set, and then fixation targets that you can use, you know, the multiple ones, the ones with the smiley and things like that. And then Logmar vision charts for distant and near. So I would like to show you some of this. So this is a 3-meter chart that we have. This is a symbol chart, and you can actually hang it, and I hope everybody can see it. Something like this you can make, and then this is again a chart. This is a 3-meter chart. This is a 4-meter chart. This is a 4-meter chart that I'm, okay, if you can't see it, so this is a 4-meter chart. And then you have cardiac acuities. This is the cardiac acuity that we use, and then that everybody knows. And these are the layers grading patterns. There are also distribution charts like this, which we call as flip charts. So you can use these charts. They are supposed to be held at different distances, and logbar charts are mandatory in this. And then you have our near vision charts. So these are the different near vision charts that we can use. And then contrast sensitivity chart. And then you have your contrast sensitivity chart. I want to say something about contrast sensitivity chart. Don't go in for Pelli-Robson. Most of the low vision patients will not be able to cooperate for your Pelli-Robson. The simple ones are Hiding Heidi by Leia, and then you have this grading charts, and actually even your Cardiff is based on contrast sensitivity. So, and color and field testing. Field testing, again, I want to caution you that HFA, Humphreys cannot be done most often because of the contrast problems. And then for the reading, writing and all that, you need to have some school books and magazines, and you need measuring tapes and your records. Records means like where you note down all that. So measuring tape is, you have to be very specific about what distance you are testing them. So that's very important. So that's why I put that there. And then your interventions are optical. There are two types of intervention: optical devices and non-optical. Of this, the near devices, you have near and distant devices. So near devices are magnifying glasses, handstand magnifiers, telescopes. And then field expanders are, you reverse the telescope and then you get a field, but then the size of the object becomes small. CCTV and Fresnel prisms. Fresnel prisms are available freely to be inserted, but again, patients have to get used to Fresnel prisms. And glare controls are tinted glasses and filters. So let me show you some of them. So this is a stand magnifier. I hope everybody is able to see. This is a stand magnifier, and this is a hand magnifier that everybody has seen. This is another type of hand magnifier that has two power ones. So you can see this. This is a dome magnifier. Excuse me. This is a stand magnifier, another model. And you have, and you know about the CTV. Everybody's got this, very expensive, but it's good for distant vision. And this is a spectacle mounted telescope that you use like this for classroom reading. And this is a handheld telescope. And this is another type of hand magnifier. And of course, everybody knows this sheet magnifier, which is easy for older people especially. So this is that. And then these are the, this is a Notex where the patient takes money. This is money identification. This is a typoscope where a person puts it on the reading material and reads in a single line. This is a writing guide where you write in between the lines. So has some writing straight lines. This is a signature guide. So older people with ARMD, they are able to, you know, just put it like this, and they can sign inside checks and all that. these are the different types of filters. So filters, which they are very expensive, and but now they are available. Only certain colors are available. These are imported ones, so which CBM got for me, and this of course. And we have the stand here. You can see. So if you can see, this is the reading stand. So this is actually, I bought it in Amazon. That's funny because those days we were in the early years of my practice, we had to run around for this, make it ourselves and things like that. But now this is available online, and this lamp is also very useful. If you see that, you can, it's very portable, and this can be used for, and I think you can even control illumination with this. So this is very useful, and this is how it can be. So, and of course your cane that is used for mobility purposes. And a cap to avoid glare, cap will come up. Then since my things are locked up, I'm showing you this is a video magnifier portable, and this is what we have already. This is a CCTV with a mouse model. So these are latest assistive devices. There are more softwares like Magic software, JAWS software, reading. There are two types of software: screen reading, screen magnifying. So these are the things that are available. Now let's come to infrastructure. Excuse me. Coming to infrastructure. So when you plan your low vision services, you have to decide about enhanced accessibility. Patients should be able to find their way in and out. So there has to be a lot of attention given to color, contrast, lighting, and glare. So especially the reflective glare tiles cannot be used. Paint has to be matte finish. You know, so this sort of simple changes that you need to make, and patients should be able to, not much of, you know, all these ramps and things like that, as preferably possible. Make it smooth from the OPD to the your department, or as close as possible for wheelchair patients and everybody. To be very careful that the floors are not slippery and they don't have glare. So these are all very important. And you also need to have light, control lighting, where you can increase or decrease according to the, that's why this whole place is so lighted up, and you can reduce the number of lights, or you can, you know, you have this control. So with that you can diminish or increase the light. One thing is, low vision is always not about bright lights. So we need to know the patient's preference. And then facilities that you will need, you will just need a room, could be 8 to 10 by 8 by 10, 8 to 10 square meters. That's sufficient. You don't need a very big space. You just need that. And one corner can be for clinical assessment, and the other corner, it has to be very non-clinical, or shall I say non-hospital atmosphere, where there's some toys and books and other things. So we have some books and that we see how they do things with, and then we have a blackboard also, where patient can write on the blackboard. It's a simple blackboard. You can actually paint the wall or paint anything, one side of a wall or something, and you know, you can check how they are doing with their device. When you are giving a telescope, you have to check out their blackboard reading and all that. So, I believe that 8 to 10 square meters, that would be about, yeah, a room, because you need a full 6 meters to measure your vision. You can't just do it as the return, the 3 meter and all. 3 meters is not sufficient. So 6 meters are definitely different. So I gave margin of 8, another 2 square meters around. So that's where, that's what we need. And it has to be comfortable and clutter free, please. You cannot put everything where the patient can crash against or dash against. All this has to be you have to be very careful about these people. So you have to make them comfortable, otherwise they're not going to talk to you. The other thing is clutter free. This is very important for a low vision patient. Then what are the other things that we have to put our mind to is record keeping. This is very, very, very important, not for legal purposes alone. It is for your follow-up. Because if you test a patient today and then you don't have any records, and then later again it will be redoing this whole protocol that we saw, which is a waste of time. And so you must know where you left, where they were when you saw them first and where they are. So that helps you to also monitor and your progress and all that. And you need a stock and inventory. See, you can't just, these devices are not available outside. And even if they are available, they are not made on optical principles. So you need to keep a stock which you can sell on the spot. So, and your glasses, magnification glasses, like you can do them in your own optical shops. Where is that? Yeah, this is a +20 with a pediatric thing. So this is ready-made. You need an assessment kit for this. And then you also keep some ready, which you can sell on the spot. So you need to maintain stock and keep a stock of devices, because most of the time our patients cannot afford in the beginning. So you need to keep a stock and inventory, and then ask them to, you can sell it on the spot. Then, so this takes us to accounting and finances. So financial burden, you have to think about what are you going to do, how you're going to do it. Then also, low vision doesn't end with you in the clinic. It also spills over to community. So community interaction, for that also you need to be aware that you have to do a lot of community interaction. And we'll be seeing for what we do that. And then comes a question of sustainability. I want to tell you at the outset that in the beginning, we cannot even talk about this. But accounting and sustainability, why I put that is you have to decide whether you're going to give it all free or all paid or a subsidy, and how much of subsidy and things like that. That depends on you. And so what is a subsidy? You're going to give 10%, 20%, 30%, whatever. So you have to remember all this when you're accounting, in your accounting. So that's why I put that. And sustainability. In the beginning, you cannot even talk about sustainability, but later on we can move into that. Since with now we have all indigenous devices available. In no way are the Indian ones less than the imported ones. So just because they imported does not mean they are good. You have to verify. You have to use them and see. So the optics are very important. So you have to find out which are and your vendors. Don't just take one company and say this is good, and then try others also. So you have to decide about all that. So again, then I talked about community interaction. So networking is very important. So why must do networking is mainly case detection. So you have to find out, you have trained people, you have infrastructure, you have everything, and then you don't have cases, then it's bad. So you have to find, you just can't say only those who are coming to the OPD. So case detection, you can network with all the NGOs in this field, and you will get a lot of cases. And then supportive therapy. Like if a patient needs occupational therapy, or he needs physiotherapy, whatever it is, for that you have to network. You have to know the places where the patient can be sent and followed up, and you need to have a good rapport with them. And then socio-economic resources. In this, government plays a major role, because our patients may not be able to afford, and the rehabilitation services of every state and Government of India, social welfare, family and social welfare has a lot of this help. So you have to send them for socio-economic resources, like can they get some free subsidy? Can they get some support for scholarships or for setting up a business, all that. So you must know the people in that government sector, like the local district rehabilitation officer and things like that. So you need to know the people who are there who can help, and also for placement. You will just can't leave them and say you go. We have to find out schools which are able to take them and train and give them education which allows them to be themselves and with your help, and vocation placement. That's very important. And I have done this more often. Education, I had to talk to the colleges and schools, and they're quite okay. So vocation placement, you can suggest to them actually where they can. You must have a list of where these people can be placed for training as well as for their livelihood. That's very important. So this also brings us to the question of advocacy, and this is very important. So there'll be others who are very good in this. So in our hospital, like for any hospital, you have the human resource, HR department, you have the marketing department. So you can use these people for this, actually for networking. You don't need a separate person in Lovision. You just have to. Then few pointers in planning. What are the necessities in planning? So you just can't straight away start. So evaluate the need in your catchment area. How much is it? What about people? So you just find out the need in the community. Then deliberate what level of services are required. You just don't start with a tertiary level. You don't think about a tertiary level with all this rehabilitation. It's not necessary, absolutely. You can build it up later. So in the beginning, that's why I said it's basic Lovision services. So deliberate what level of services are required for your program, project or hospital, and then consider networking. If there are things not available, start networking. Just because you don't have a functional person or a rehab person, don't just leave it. You network with somewhere, send them somewhere where they can get that information and bring it back to you. So we do a lot of networking like that. We send them for active evaluation and different types of evaluations. So networking is very important when you're thinking about the level of services. Then analyze your financial commitment. How much are you going to be able to invest in this? My thing is that you would need only a 2 to 3 lakhs in the beginning. That's all. It doesn't. You don't need more than that. You really don't need more than that. If you're setting up starting small and you don't have the basic things and all, you don't need much. And then determine how to incorporate this into your existing organizations, institutions framework. Right? You have to. This is a very important one, that you have to try and incorporate and not demand this has to be there and something like that. But you have to incorporate into especially the timings. So in the beginning, maybe you can set timing for your people. Once you pick up, like in our hospital, we don't have separate time. As and when the patient comes, we do them, and then we manage the general OPD, special OPD, everything together. So you have to find how you can work within your existing framework. So caution in planning, as I was saying, there are 3 things that you have to keep in mind. There are many things which are necessary to have. Okay, so the basic stuff that I told you. Then there are some things which are good to have, like your belly robes and all these assistive devices right there. And there are some things which are nice to have. But at the outset, I would say, stop with what is necessary. Don't plan for a big. That's why my budget is very small, 2 to 3 lakhs. So what is necessary will fit right into that. And what is good to have when your services expand and you're going up, when you're expanding your services, your level of services, then you can think of these good things, all, keeping your computer training and all your softwares, all these assistive devices, so many of them. Some of these assistive devices are 2 lakhs and 3 lakhs, which is not necessary right now. So that's good to have. And nice to have is, I don't have nice to have at all. So even though we are a tertiary level eye care, especially in low vision, we are a center of excellence, still there are many nice things which I still don't have, and I don't think it's necessary, because after all, our thing is to reach out to the patient, the person concerned, and see that they are okay. I mean, they are back in the community, living their lives. So that's the caution and planning. And that's why my finance, you might think my finances budget is very low, but I think that's more than sufficient. If you want, you can stretch it up to 5 lakhs. So to conclude, service delivery to those with vision loss, which is towards community integration by establishing these clinics, should have, if you see, have been listening closely, it's a holistic approach. You don't just see the clinical part of it, eye care part of it, and then you send them. You have to do a holistic approach where the patient's livelihood, his economic status, everything comes into play, and you have to take, you have to at least coordinate for them. Even though you may not do it for them, coordinate there and see that they are in. And again, the service delivery should be in a phased manner. So low vision clinic can start small, and then you can keep adding things. There is a scope for everything. And I also find that as you move on, many things becomes obsolete. What was necessary has become obsolete because of technology development. Again, don't go in for too much of technology, because most of our patients are from the lower strata of society or in the rural areas. They may not have all those things. So, but with all this gadgets coming up, your smartphones, you have softwares which can be used on smartphones. So, many things that's why I said it's better in a phased manner. And thank you. I want to thank Dr. Nelson Jesudasan for his support for me in all these years. And thank you all for patient listening.